Well, thank you, Victor, and thank you all for inviting us to this interesting presentation opportunity. So I'm going to take a little bit of a different tack by looking at a broader perspective that has evolved over maybe some 65 or more years. And my message is really focusing on the general broader category of computer-based clinical decision support and intelligent systems in health. And that's been evolving. And you heard a lot about the earliest efforts in diagnosis, treatment, and prognosis prediction. And these are largely focused on the patient-doctor encounter or an academic exercise simulating that. What we evolved to is a much broader way of integrating decision support and intelligent tools into the care process. And I'm going to try to cover that. It involves multiple participants and roles and tasks. And I think instead of really just talking about decision support, in fact, we talk about knowledge-enhanced health and the healthcare system. And AI, as we've talked about, has been and really is a large part of that story. But I think we're moving toward what I would term a co-intelligent health system. Now, the term co-intelligence is borrowed from a wonderful book by Ethan Mollick at University of Pennsylvania called Co-Intelligence. And it really emphasizes the role of a tool or an application as a collaborator or as a colleague to the coach, not just a competitor or a sycophant that just says yes to everything. So it's a more nuanced view, and I think we're moving toward that. And I think it helps to kind of reframe the whole conversation about where we're heading in use of intelligent systems in health. So I'm going to give you my version of a tour through the decades. I started the field actually in 1962 when I moved to Harvard to Boston to start Harvard Medical School. And it was a kind of interesting time, as you'll see, because it overlapped with a lot of the pioneers that I got to know, many of those, during the period from then to the present. But when I got there to enter medical school, the highest technology that we really had was a stethoscope, an X-ray machine, a clinical laboratory analyzer, maybe an electrocardiogram machine. By 2 years later, there was an early project starting between a commercial entity in Boston, Cambridge actually, and the Mass General Hospital to build one of the first electronic health record systems. It was led by my friend and colleague, Dr. Otto Barnett, who's passed some years now, but he was the medical director of that project, and I got to join it. But the technology at the time was a very limited mini computer, a teletype, and paper tape, and before that, and in some applications still using punch cards. So we went from that to a naive view that we could automate the medical record. But actually, beside that naivety, as people have already mentioned, work was already going on in the world of AI. The first neural network, which was actually the perceptron, we've mentioned Frank Rosenblatt at Cornell, started the work in 1958. I got to know everybody else on this screen. Ledley and Lustig published a very famous paper called Reasoning Foundations of Medical Diagnosis. And this arguably was the first focus on using computers in health. It focused on logic for the diagnostic process, Bayes' theorem, as we've talked about, and value theory, which was a precursor to decision analysis with utility theory. We talked about John McCarthy and Marvin Minsky and their roles in early AI. When I finished my medical degree, I went on for a PhD in computer science, and one of my colleagues who served as my on my PhD thesis committee was Joe Weizenbaum, who had developed a program called ELIZA, which was a first attempt at kind of being a Rogerian psychiatrist, a kind of reflective dialogue with a human. And so you could argue that was the first chatbot. Now, the tour I'm going to do is kind of briefly by decade. So starting with the 1960s when I got involved, the first EHRs were actually, you can think of them as a platform for developing clinical decision support. We talked about diagnosis, and non-AI approaches, Bayes' theorem, as postulated by Ledley and Lusted, were actually implemented by Homer Warner at University of Utah and Will Ladwick at University of Columbia, Missouri. And there were also attempts to use algorithms and computational methods for well-defined problems. This was already going on. EKG analysis programs were already developed, programs to advise on acid-base and electrolyte balance and corrections of that. Radiation dosimetry calculations, looking at multiple portals and trying to figure out the best combination, were all underway. In the 1970s, as Pete and Ted talked about, they're young ones compared to me. So I had a decade on them looking at some of these earlier approaches, but they advanced a lot of initiatives in cognitive modeling and heuristic reasoning, as Pete talked about, and rule-based systems, as Ted mentioned and described with his early work. We also, though, saw early attempts to use databases that were collected systematically to be able to do prognosis and prediction in a clinical care environment. Excellent project in arthritis and rheumatology at Stanford, and another project in cardiovascular surgery at Duke University were early prototypes of that. And also in the 1970s, there was a broadening of scope of where we could use intelligent systems. And this involves monitoring of activities and events. And a colleague at Indiana, Clem McDonald, developed a reminder system that was triggered by the medical record and published a paper that started a whole effort in looking at monitoring, and it took the form of alerts, and which would occur like if an abnormal result occurred, surveillance, for example, studying quality and efficiency and efficacy of various procedures over time, or actions by doctors or by patients. You could then do analysis of what worked and what didn't work, and actually create a feedback loop back to providers, kind of a slow feedback that would allow them to improve their behavior. In the 1980s, there was more focus on process rather than instantaneous events or focal diagnosis or treatment problems, looking at how physicians ordered or prescribed medications or procedures, and CPOE, computerized provider order entry, came on the scene, along with drug-drug interaction checks and drug test interaction checks, how you might get abnormal elevations of a test result, for example. And then decision analysis, which basically incorporated Bayes' theorem with decisions on if you have a condition like pain in the abdomen and you think it might be appendicitis, do you treat, do you test, or do you do watch and wait? And then what happens as a consequence of each of these, and then what ultimately occurs if you do the test and it's positive, and then you decide to operate or you don't operate. And what it does is take the consequences of the outcomes judged in various ways called utilities, based on either on dollar cost or mortality or morbidity or risk fear, other kinds of metrics. And so a lot of work was going on in understanding that. And it carried even further to involving the patient and the patient's own preferences, for example, pain avoidance or increasing my life at any cost. And a study was done looking at laryngeal cancer and the treatment of surgery versus radiation in terms of how it might affect the patient and incorporating patients' preferences in that. Now, jumping ahead, I'm doing a very whirlwind tour here. The 1990s looked more at processes like the logic rules of the alerts and reminders, and often these were event triggered by a result occurred or a time elapse occurred. And then also expanding into guidelines and protocols for care that unfold over time. And I actually had the opportunity to work for many years with Ted Shortliff on a project between Columbia, Harvard, and Stanford on that, also involving Montreal for a while, although the Montreal person, Ted's wife, have moved to Columbia. Anyway, also in the 90s, there were beginning to be concerns about safety and quality of healthcare. This was triggered by a study out of the Harvard School of Public Health and then by Lucian Leap and by David Bates, who identified medical prescribing errors as one of the leading causes of death. In fact, it was preventable medical errors were found to be the 8th leading cause of death in the United States, which was shocking. Well, this led to a whole decade really preoccupied with how to improve safety and quality. Part of that was stimulated by a report called To Err is Human, which came out of the Institute of Medicine, which is now the U.S. National Academy of Medicine. And another report called Crossing the Quality Chasm, and in fact, a series of 8. And there were a number of stakeholders involved, agencies and consortia. And these largely led to a stimulus program in the United States in the late 2000s to stimulate the adoption and use of electronic health records, CPOE, the order entry, clinical decision support, health information exchange, and the use of standards for sharing. And that blossomed in the 2010s with widespread EHR adoption in the US, and to some extent that followed elsewhere throughout the world. And the other thing that happened during the 2010s was a focus on moving away from just transactions and encounters with the health system when the patient was ill or had a problem, but rather maintaining and preventing disease, maintaining health, preventing disease, doing early intervention, being more patient-centered. And this was kind of, in a way, fostered by having more and more data available about the patient and being able to harness analytics and monitors and sensors to be able to track what was happening. And the other thing that was an important focus is cognitive processes and how one might augment them and facilitate doing the right thing. In other words, the idea of maybe making the right thing the easy thing to do through checklists or predefined order sets, structured data forms, structured reporting, and then visualization aids like dashboards showing important trends and graphing and so on. And also being able to identify the context of the care process by being able to identify needed information at the point of care based on context. Now, I'm jumping ahead now to the current decade, and we're moving to kind of a more holistic view for the health system. In the US, there was something called the quintuple aim. This was triggered in part by the inequities in healthcare, but also by physician burdens from health records and other regulatory requirements and so on. So there was a lot of burnout and people leaving the profession, also nurses. So the quintuple aim is trying to have better health, better experience by the patient and the provider, lower cost, and improved work life for staff, as well as equity. And the other concept was the idea of a learning health system that continually improves based on data, analysis of the data, outcomes, and determining kind of ways to improve the system, and then implementing those, collecting more data. So together, these kind of lead to what I'm calling the knowledge-enhanced health and healthcare environment. The AI explosion, of course, occurred just hard to believe 3.5 years ago, made possible by the very large databases that were already occurring, the machine learning and deep learning networks, large language models that we talked about, but also, and I think my colleagues haven't really mentioned this much, but agents that will carry on out various tasks for you. And this is blossoming. And the AI impact areas, are all over the place in science and genomics, precision medicine, applying this to actual care processes, pharmacogenomics, and picking appropriate drugs based on the genomic characteristics, imaging and interpretation of images, predictive modeling, but also in the care process itself. And this is more than just diagnosis and treatment, but the patient interaction process, triage or initial screening, identifying the problems and concerns before the provider sees the patient, encounter notes, track both the past information and also capturing the encounter with the doctor, summarizing the notes, helping to transcribe it, patient education, and also being able to surface relevant information and alerts and reminders in a context-aware manner. On the patient front, patient has multiple resources available, sensors and apps and all kinds of tools, and it can be an omnipresent aid, again, providing data, also alerts and reminders, and communication when needed, and facilitating their own self-management of disease. So what I'm getting at here is that we've had over the decades kind of an expanding scope from finding information, making decisions, performing computations, monitoring, managing, and optimizing the care process, organizing and summarizing information to facilitate cognitive process, and ultimately now carrying out and guiding the CDS process as needed. So viewed kind of holistically, I think the computer is functioning kind of as a partner and a collaborator. It's not just in isolated situations where we want to ask it for a diagnosis or treatment advice or a prognosis, but it becomes a participant in the whole process. And just to kind of illustrate this, I think there are a number of cycles that occur in health. There's the patient care process, where patients see providers, they get various tests, they maybe get x-rays or imaging studies, they do other procedures, and other participants are involved, and the process iterates. And then I mentioned self-monitoring. That's another cycle that is occurring, and they interact with each other. Patient, alert it gets triggered, or the provider prescribes a self-monitoring regimen, and so on. So, and the providers and the patients each have many roles in these different cycles. And also, you have to remember that providers see many patients and they have to optimize their overall activity. So this leads also to kind of another cycle that they participated in, and that's the enterprise or office or practice cycle of trying to carry out the business of seeing patients, taking care of patients, but also doing it in a cost-effective, high-quality, and financially sustainable way. So participants have to operate within an organizational framework. And then, as we mentioned, all these processes generate data, and we have analytics that can occur to identify risks or situations that need intervention, and communication with those individuals with feedback and hopefully modifying behavior. And on a generalized level, we're in this virtuous learning cycle where practice and the data generated by it feed into a learning health system that evolves over time based on the other three cycles. So, and all these cycles are interconnected, as I've kind of alluded to, and there may be other cycles that I haven't even included. So my message is that if we consider capabilities of smart systems and intelligent systems in the context of the entire system, it's not only how they support individual participants and how well they work, but also how they fit into the workflow and how they support the overall care process and the healthcare mission. And at each point in this whole complex set of interactions, it can function better if intelligent tools help us to provide awareness of relevant information and anticipate tasks and supporting actions. If you look at the individual tool or app, we also need to maybe improve our AI. You know, a chatbot kind of gives you what it thinks you want. It's kind of a sycophant, tries to please. But maybe we can, and you revise it only when you say, well, I don't like that, change it. So, but a co-intelligent environment might be more of a interactive process where it can make suggestions based on context triggers, and participants react and revise and counteract, and the process iterates. So I think we can look at individual smart tools and refine them along these lines as well. But the overall system as a co-intelligent system is the main point I want to make. Now, there are a lot of concerns, obviously, with AI systems, and my colleagues have touched on some of these, but others, like AI is making the provider irrelevant or obsolete. I hope I'm showing that that's not true, and that there are many ways in which we are improving our care process and the overall health system by interacting with AI. You could argue that AI lacks empathy, but actually there's some studies that, including at my institution here in San Diego, that published results showing that in some scenarios where a medical response was generated for a patient question, the computer-generated response was deemed by a panel of observers as being more empathetic than the human. So I don't know. I mean, I think if you can include in the intelligence of systems awareness of patient preferences, emotions, kind of emotional intelligence, as well as social intelligence, I think they can begin to be more empathetic. It's kind of a expanded view of intelligence. Whether it can be biased or unethical, we always have to be mindful of that. We don't want unchecked AI. So a lot of these are concerns that I think the whole field is preoccupied with. But I think my main message, and my conclusion, is that there's been a major evolution of scope. And the participants in the health system are part of a co-intelligent system. And this is actually not a conclusion, but still a beginning. And my overall view, in case you haven't realized it, is optimistic. So watch this space. Thank you.